Mandy, do you want to start and tell us how you found Dr. Patrone and also share your experience with him today and why you're there?
Okay, Kim, well, I'm nosy and I research a lot, which you absolutely know from all the stuff that I post on Facebook. And I managed to find a conversation between him and Jane Mustafa online and noticed it had a little Union Jack next to it. So I investigated and found out that he was indeed in the UK and he's in London, northwest London. So it's taken me 3 hours to get here. And I have to say, I've had an ultrasound scan, which is much clearer than the MRA that I had. And I know exactly where my arteries are, how blocked they are. And I've said hello to all of my arteries, thanks to his very, very talented guy. It's been brilliant, absolutely brilliant.
Wow. And Dr. Patrone, you know, your thoughts after seeing Mandy today. It's so amazingly rewarding to know that. I mean, Mandy, what did your other doctor tell you before? They were saying that there was no hope.
No, they just said I would have to go straight to bypass if and when it gets bad enough. The thing is, Kim, I had an MRA scan and 3 different surgeons told me different replies to what my scan told me. So I had to find out the truth. And although I'm not at a stage where I need a load of surgery now, and luckily enough, Dr. Patrone has reassured me on it, I've just seen all my arteries, one of which I've been told by 3 surgeons isn't there.
You know, the thing is, like with this kind of exam, a duplex scan, if it's done by someone who's really good at that, you know exactly, you know, what's going on, checking the artery step by step, coming back if you need. There's no contrast involved, so there's no time with the machine. Everything is live. You know, the patient can see the arteries, and we can really come to a decision, to a solution, to a prognosis really quickly. So we don't have to wait for someone to report. It just, everything is live. And that's, I think, the added value of this scan. In my center, we use duplex scan for most of the patients. I would say more than 90%. And we just ask for CTs on MR just for patients who are like obese or can't go for a duplex scan for different reasons, for ulcers. But it's like, let's say most of the patients, more than 90%, are just diagnosed with duplex, and from the duplex straight away on the table if they need.
Right, we have a comment from Debbie Louise here. She said she had to go straight to bypass, no stent, software. There was just nothing. And what?
No, but I showed her an intervention I did just yesterday for a patient with extensive tissue loss at the level of the foot. And we recanalized the artery from the ankle joint. So I punctured a small artery, which is a posterior tibial artery, 2 millimeters of artery, going up to the thigh, which were all occluded. And at the end, she had a fantastic biphasic flow at the level of the ankle, and probably she will heal from the ulcers. So, I mean, we did this, which is usually, she was a typical patient for surgery. And we tried, and we were successful in recanalize everything endovascularly with just 2 small cuts, one in the groin and one a really small one on the level of the ankle level.
And we have Elaine here who also says she had 1 stent that failed after 5 months and then straight to bypass. What advice do you have for patients who are in this situation like Elaine or Debbie or even Mandy, who, when their doctor says bypass is the only option, what follow-up questions should patients ask or research that they should do in order to decide whether or not that is their only option, or if there's something else that's available to them?
So I would say that in patients who are really young, like 40 years old or 45, and they have like a situation which is not that bad, I think the bypass is a good option, because the bypass at the moment has the means demonstrated to have a really good long-term results. For people in need who are like 60 plus, let's say, and if they have a good doctor who's good with wires and catheters, who doesn't destroy the arteries, because it's really easy to destroy arteries in this way, I think endovascular first should be the option. And actually, you know, I'm going to conferences and debates, you know, trying to bring my message, and which is not just my message, but it's the message of the whole community of more skilled guys. So endo first for everyone, apart from really few cases. And, you know, if that fails or when it fails, it anyway buys time. And then, you know, bypass, it's sort of, you know, not last solution, but, you know, a further solution, let's say.
We have a question from William Smith, who is asking about amputation is the only option for PAD. That really just falls right in line with this conversation, that it's not the only option.
No, of course not. I was also talking to her and saying that, amputation is not an option till really the last stage. You can even try to do, extreme revascularization and try to turn 180 degrees on, when you're going towards amputation. But amputation is just for the patients who are dealing with too much pain, so they can't really live without pain, and where all the surgical and endovascular options are finished. So I would say there are many cards to be played before going for amputation. There's a patient who's going to see me next week, who's going to come from Scotland because he has rest pain. He does have some artery disease, and they didn't even try to revascularize in any way. No endovascular, no bypass, nothing. And they wanted to go straight for amputation. That's the thing that should never, ever happen. People going without any kind of probably vascular, opinion, any vascular attempt to revascularization, straight to amputation. This is in the 2019, it's something which we can't accept.
Carolyn is asking about flying with peripheral artery disease. Is it more at risk for people?
No, no. I mean, the most risky thing when you have really bad artery disease is to cut your nails, the nails of the toes. This is the most risky thing you can do. So my suggestion is try to do it. If you have a really bad vascular disease, to be done by a podiatrist or by someone who's an expert, because small cuts can bring you to infection and can bring you to amputation. But flying is not a risk at all.
And Michelle, she's our admin here in the group. She says some doctors say no to compression socks and other doctors say yes to compression socks. Where do you stand for people with peripheral artery disease? Compression socks, is there any level of compression socks they should be wearing? I've heard no for people with peripheral artery disease, but only for people with venal issues.
Yeah, that's a really good question, actually. So compression stockings, of course, the name says that they are compressing. Because they're compressing the veins, they're trying to squeeze the veins towards the groin. And so for this reason are also compressing arteries. So I think a good cutoff is to do an ABI test. So you check, how bad your arteries are. And of course, for example, if you have an ABI of 0.4, I absolutely wouldn't suggest to go for compression stockings, despite even if you have, venous ulcers, which are treated by compression stockings. So in a case you are really in need of compression stockings, you need a revascularization first. But first you revascularize, you reestablish a good ABI ratio, and then you go for compression stockings. But, never go for compression stockings if you have a really bad peripheral artery disease, because it can get even worse.
I have a question from Linda Monte. She says, I had a stent for CTO of the popliteal artery 18 months ago. The stent is now completely occluded with thrombosis. What should be my next alternative? And maybe what question she asked.
This is a really good question. I strongly suggest to people to go on Vascupedia, which is one of the websites. It's a bit for clinicians, but I think it helps you a lot. And I'm working now to make it more accessible to patients. But I debated, and I was the expert of the month 3 months ago, about in-stent restenosis, in-stent occlusion. So the stent occlusion, the complete occlusion, which is chronic, it's not like, if it's fresh, you can go for any kind of lysis, so drugs which are dissolving the clot. But if it's chronic, then could be an issue. So you can go, let's say, in 2 different ways. So 3. One is to do nothing if the symptoms are not bad. If the symptoms are bad and you need to do something, there's an endovascular option. You can use atherectomy devices, drug-eluting balloons, or just balloons, and try to open the stent at least once. I would say at least you have to try once to open the stent again, or if not, there's the bypass option. It depends how long is the stent, how bad is the occlusion, how recent. So every story is different, but there are always 2 options. The results are not amazing, I have to say. Literature are saying, it's in the long term, the patency is less than 17%, but there's always a hope, and you can always try to open these stents in some way or to do a bypass. Of course, the stent which is blocked doesn't mean amputation.
And Terrell says, I am 25 years old. I'm suffering with PAD. What are the reasons behind this? Never smoked, never drank. Nothing.
That's a genetic disorder. Absolutely, 100%. So these people have this kind of different pathologies. One could be correlated to the blood flow. So it could be like hematologic problems, antiphospholipid syndromes, or something like that, where the vessels are thrombosing despite being patent. The other disease is the Berger disease, which is another pathology which affects young people, and it goes far worse with smoking, but also without smoking could be quite bad. And all the other stuff are genetic disorders, like any kind of connective disorder. So any kind of, Ehlers-Danlos, Marfan, these kind of connective disorders, which are affecting the flow in this way.
Fantastic. I think we have some more questions that are coming right now. Debbie is asking if, I'm not sure what Debbie's question quite is, something about a factor versus effects pad.
As factor V is the thick blood. She's got factor V, Leiden, the blood disorder.
Yes,
Exactly.
yes.
So she's worried that that makes her vascular situation worse, because obviously a blood clotting disorder is, I've wondered that too. I have thicker blood, not the disorder, but I've got thicker blood too.
This is what I was talking about. I mentioned the antiphospholipid syndrome because this could be one of the causes of early thrombosis. Yes.
Oh, fantastic. Any more questions coming in here? We're getting a lot. We're getting so many questions that they're just scooting right out of my screen.
Well, I'm going to say goodbye and leave you with Dr. Patrone, because I've got 3 hours home, Kim.
Thank you so much. What is your best advice, Mandy?
I'll tell you, the best thing I've learned today, Kim, and I'm going to tell everybody, is I had an ultrasound scan before in May, and I've just had the one today here. And I'm hoping that, I know Dr. Patrone would tell me the velocity difference in those 2 scans. He's going to tell me exactly, but I already know they've increased a lot, and they've increased because I just keep walking. It's the only explanation, just keep walking. So I'm over the moon.
So she brings up a really good point about growing collaterals. And can you talk a little bit about how your body grows these collaterals and the importance of walking?
Of course, yes. Every time there's a blockage, there's always the possibility of the body reacts really well to the blockages. So it tries to develop small vessels which are going around the area which is occluded, and this flow, of course, at the beginning is really slow because these vessels are small, but with the time, and if you push blood into these collaterals are growing bigger and bigger, and that's, I'm not saying it's the same as having the native artery, but most of the symptoms can go away just if you develop these collaterals. And the only thing you need to do is to pump blood in these arteries.
We have a question from Jay Lee. I have an occluded right leg bypass. Any options for him?
Is it occluded?
It's occluded.
Yeah, I mean, did she ever try to have any stent or any endovascular treatment?
No, it doesn't seem to be the case.
Okay, so I think, definitely I've recanalized different people who had 1, 2, 3 bypasses, and then, the endovascular intervention lasted longer than any other bypass. So yes, go for endovascular, because I think it could be a good option. Find someone who's good, because this would be probably a bit more challenging, but definitely, it's definitely an option.
It's interesting. Here's an interesting question from John. I've had a bypass and stent, but now all blocked again. The consultant is talking about another bypass. Can I opt for the way he puts it, the artery drill? So he's basically saying, how can he get an endovascular procedure and demand that that's what he wants next? He doesn't want another bypass. How will he?
I mean, it's a matter of finding the right specialist for the right thing. So if you find the right endovascular guy who can try to solve the situation with an endovascular intervention, go for it. If for any reason you can't, the second bypass is always an option. I mean, it's of course it's a bit more challenging, because also you need to dig in a groin or in a artery which has already been, that's sort of scarred by the bypass, but it's still an option. My option is always, whenever you can, first option or second option, or whenever you realize, go for endovascular.
And Michelle has a question. Is there anything natural to take to prevent claudication and increase the space within her circulation, turmeric, ginger root, CBD oil. There are a lot of discussions in these groups about natural methods, citrus bergamot, K2MK7, and on and on and on. What is your experience with some of these supplements and patients who have been taking them? Do you see results?
No, not really. The thing is, like, the main thing is try to avoid risk factors. So avoid smoking, avoid hypercholesterolemia, avoid that, you know, any kind of diabetic factor. These are the main things. So it doesn't matter if you eat like 2 carrot cakes a day and then you eat some ginger, it doesn't change, you know, the situation. The main thing is to have a correct diet with the correct amount of sugars, correct amount of carbohydrates, and then especially if you're diabetic, to control the diabetes. If you are in this situation, you are a winner and you walk. If you don't, then, you know, there's no other, you know, magical trick to remove I mean, when you have the stuff in your arteries, there's no way to remove it, first of all. But to prevent the accumulation of this kind of plaques, you need just to change your lifestyle. And, you know, that's the main thing. Don't go to any kind of natural remedium, because it's not demonstrated to be effective.
And Michelle has asked, she's scheduled to have a femoral bypass on Tuesday, and she wants to know about what she should expect in having that type of procedure. You talked a little bit about it, and you know that people should make sure that the doctor has ruled out every endovascular option. But if you do have to have bypass, what can you expect? What's the procedure like? What's the recovery like?
So it depends a lot where the bypass is landing to. So there's a fem-popliteal bypass, which is the most common bypass in the let's say in the vascular field, which has of course the higher patency rate, especially when done with the vein. And there's the fem-popliteal, distal popliteal, or a fem-distal bypass. So the lower you go with the bypass, of course, the lowest is the rate of long-term success. What you need to expect are 2 wounds, one at the level of the groin and one at the level of the landing zone, which could be, as I said, the popliteal. So say the distal thigh, or the distal popliteal at the level of the popliteal fossa, just behind the knee joint, or if the bypass is a fem-distal bypass, it would be probably at the level of the ankle. And whatever you do when you cut, it is always could be a complication. The complication can be, you know, an infection, could be some bleeding, or could be some lymphocyte. So that means there's some sort of fluid which is really clear is coming out. But don't worry, because I always, you know, there's always a solution for everything. It's just the recovery time could be different. So a normal bypass, let's say a fem-pop bypass, the patient can be discharged in 4 to 5 days from the hospital, even earlier. And if the bypass then is not healing really well, maybe the patient stays 2-3 weeks in hospital, but then, you know, usually at the end, everything goes well, I have to say.
Wow.
So good luck for your bypass.
Yeah, it really makes you want to make sure that the doctor has exhausted every endovascular option available before having a bypass. We have a question from Brian in the group. He wants to know why his feet still swell and he's having difficult sleeping. Although my wounds are getting healed, he wants advice if he may still have clogged arteries. He said also both his hands are numb, and he said he does have a tentative scheduled appointment with the vascular doctor later in October, but he wondered if he needed to get in sooner. Is it normal to have your feet still swelling? Does that represent a potential block?
So, yeah, I mean, it doesn't make a lot of sense with arterial disease. So the feet swollen or the legs swollen are because usually of the venous disease. So when there's or venous disease, which could be correlated to the superficial veins, like the great saphenous vein, when you have also skin changes, or it could be like a heart pump problem. So the blood is going down also because the gravity is helping, but you know, then the blood doesn't come up again with the veins. So that's why the legs are swollen. Usually the swollen legs are a symptom of a venous disorder. And I think, you know, every time, as we said before putting the compression stockings, it's good that you go for ABI, so you know what your arterial situation is like. So whenever you know the arteries are fine, then you can put a compression stockings. You can think about treating ulcers or venous disease. But if you don't know the arterial, supply to the leg, then it's difficult then to treat the venous.
But I do like when you were talking earlier, the fact that, you don't just perform an ABI, you actually go the extra mile and perform a duplex ultrasound.
Oh, of course. I mean, the thing is, like, if the ABI is 1.2, there's no need for a duplex ultrasound. If the ABI is a bit lower, it's like 0.6, 0.7, 0.4, yes, of course you perform an ultrasound. But the first step, every GP should provide an ABI, because it's really simple. You just inflate your manometer at the level of the brachial. So ABI stands for ankle brachial index. So it's the ratio between the pressure in the arm and the pressure in the leg. So everyone can do. So you don't need to go to any specialist. You just have to do it with your GP or your general practitioner. Whenever this is not right, of course, go for a duplex.
If you are a diabetic, however, is it true that you could potentially get a false negative and that you should follow up with a duplex ultrasound?
Yeah, of course. It depends. It's not just diabetic people. Everyone can go into a negative. I'm saying if the arteries are really calcified, so really heavy smokers, diabetic people, people who have really swollen legs, these are the people, or also people on dialysis, these are people who don't have a good, reliable ABI. So, but the ABI, it's not reliable when it doesn't make any sense with the clinical symptoms. So if someone comes with an ulcer and they have an ABI which is high, it doesn't make any sense. And at the same time, if the vessels are incompressible, that means, the vessels are so calcific that you can't really check an ABI, of course you have to go for a duplex. So
Debbie has a question. I had aorta bifemoral, and what is the lifespan, she wonders, on it based on your experience?
I mean, the bigger is the tube, the higher is the patency. So if the tube is big, like an aorta bifem, which usually is 10 millimeters, I would say the patency rate is really high. Once it's done and the patient has gone through this kind of complex operation, I think the patency rate is really high. When we're talking about vessels like the SFA, which is 5 millimeters, you can see, you can say the patency rate sometimes is lower. But aorta bifem is the bypass with the higher rate of patency.
And Mariana was asking, she said she was prescribed Daphlon, 1,000 milligrams daily claudication and increase the space within her circulation. She stops taking it, she starts to feel her claudication. It helps, but it's expensive. And she wants to know if there's anything similar out there that's cheaper. And she's even asking about turmeric or cannabis.
No, you know what? Daphlon has never been demonstrated to be effective. The only good advice I can give to anyone who has claudication, I know I've never tried myself, but I've seen loads of people walk through the pain. You set up goals. You set up, today I'm going to go from my door to door number 120, and the day after I need to go to door 121. If you do that, you will be successful, because you will, slowly increase, as we said at the beginning, your walking distance by the collaterals. So there are no drugs. You just have, it's a physics. You have a blockage, you have to develop big collaterals to bring the most of the flow down into the artery, which is patent again.
Wow, thank you so much, doctor. Is there any final advice that you have for everyone? We'd love to have you to come back, but is there anything that you want to leave everybody with today to give them a little bit of good energy?
I would say do your best with walking. That's the first thing for everyone. The more you walk, the more you develop collaterals, the more you keep active and positive, first of all. The second thing is, like, whenever you are not convinced about an opinion, always go for a second opinion. You can change your life with a second opinion. You can open your mind. You can also try to understand better, what the first doctor has told you. And the third advice is never lose the hope. So try to fight your battle. We know that PAD is a battle you have to fight 24/7, every day of the year. We are here for you. We treat your vascular disease and we treat you as a person. So try to find someone who you can connect with, someone who has also the interest in you as a person and not just you as a vessel.
You said something you said a lot of important things, but one thing that just really stood out to me, because we get a lot of pushback from different patients all the time when we they bring us their diagnosis, the treatment their doctor plans, and we say, whoa, 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 hold on. Bypass, amputation, have you exhausted all of your endovascular options? Has your doctor exhausted them? And they say, no, 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 well, I trust my doctor. My doctor has all these credentials in a big name hospital, big university hospital. So obviously I have the best care team. And so if he says it's true, it's true. How do you respond?
I mean, it depends. I mean, let's say most of the times, whatever a specialist says is quite true. I mean, it's like, of course, if you came all the way through medicine and through your training, usually you're not stupid. So it's not like there are few people in the world who have just the knowledge, and many people do a fantastic job. But especially when you talk about amputation is an end. So you should definitely ask for a second opinion. If they say, especially if they didn't try anything, like as I said before, the patient from Aberdeen will come next week. They never tried anything, no bypass, no endovascular, and they're sending in for amputation. This is not good, because this means that they didn't even try. And the patient doesn't have any kind of particular vascular disorder as I asked him. So for example, if someone has a Berger disease, he doesn't. So this is the typical occasion where you need to ask for a second opinion, I think.
And we do have one more question that just came in. John says he wakes up every morning with both arms experiencing pins and needles. Is this related to PAD? Pulses and
no,
have been
I would say no.
Okay.
Because if pins and needles is always nerves. So especially when you wake up, it's usually people with PAD have a disease which is affecting them during the nighttime. So when the blood flow is not going by gravity to the toes. So this is the typical, or when they walk and they can't, because the muscles are requiring more blood. Pins and needles means nerves. And of course, it's painful, but the vascular disease is the minor of their problems, I would say.
Thank you so much, Dr. Lorenzo Patrone. We really appreciate you. If anyone wants to reach out and ask you simply for a virtual case review, second opinion, what's an email, or where can they visit to get in touch with
me? They can find me on social media, for example. I'm on Facebook, I'm on LinkedIn, but they can find me on my email, which is my name and surname, lorenzo.patrone@nhs.net, which is National Health Service here in UK. And I'm happy, of course, to be contacted by anyone. I get in touch with many, and they come here all the way, like she did, 3 hours, or they're even taking a flight from Aberdeen, which is probably 2 to 3 hours flight. I don't know. I've never been there, so I can't really say. But they're coming because if it's needed, we are here for them. And we are humble people, but we're trying to do our best for them.
Thank you. You definitely are. We really appreciate you.